Welcome to this presentation on gait and the wounded foot. At the end of this presentation, you will be able to observe gait abnormalities that contribute to or are caused by foot wounds. Select appropriate footwear for patients with foot wounds and select an offloading strategy to redistribute the pressure on the plantar foot surface. Wounds on the foot are usually associated with diabetic neuropathy, joint hypomobility, or arterial disease. The joint hypomobility at the ankle or MP joint is common after foot surgery. The arterial disease can either cause the wound or can complicate wound healing by wounds of other etiologies that may occur in the lower extremity. This chart shows the components of the gait cycle and helps us to understand how gait abnormalities can contribute to wound formation. Note mid-stance and terminal stance are 40% of the gait cycle, and as we shall see later, this time increases for a patient with diabetes. Note also the shift of the weight to the forefoot, where most diabetic foot ulcers occur during the terminal stance. Stance phase typically lasts less than a second and is about 60% of the gait cycle. It begins with initial double limb support with both feet on the ground and transitions to single limb support with one limb on the ground and lasts less than a half of a second. Then we transition again to double limb support with both feet on the ground. During the swing phase, the reference foot is not in contact with the floor. It's during this part of the cycle when we transition from single limb support to push-off that we develop the increased peak pressures and the increased shear forces that are so detrimental for patients who have the changes in the foot that come with diabetes. The critical range of motion for normal gait and to avoid peak pressures are as follows. At the ankle during the stance phase, 10 degrees of dorsiflexion and 20 degrees of plantar flexion for push-off and 5 degrees of eversion at the subtalar joint. At the MP joint, 50 to 60 degrees of dorsiflexion is needed for push-off, and this is the range that's lost with a lot of foot surgeries, for instance bunionectomies and toe realignment. And deficiency here is the cause of shear stress in the deep tissue that results in an ulcer at the plantar first metatarsal phalangeal joint. At the IP